be here. It's Monday morning here in Mexico, and it's great to be here.
Okay, so good morning to you. So Aishwarya, more than 225 registrations, but I think by now very few have joined by now. Huh?
Don't worry. We can wait.
Yeah.
It's happened in some
We
webinars,
have started YouTube Live as well now. So I think we will have
YouTube Live also. So metrics for that will be separate, huh?
Yes.
Okay. Great.
So Dr. Carlos, I hope you have received the micro rundown which we have shared before. So I will just brief you again. Once your opening remarks are done, you can introduce the first speaker for, the moderator for today's webinar.
Moderate, yes.
Yes, and I'll be sharing the screen with the details.
Yes, I understand that I have a couple of minutes to opening remarks and then welcoming to moderator, and that's it, isn't it?
Yes.
So you will read the bio of Poonam, which will be on the screen for you, Carlos.
Sorry?
You will introduce Poonam as the moderator, and her bio will be on the screen, projected by Aishwarya.
Okay, it's
which
okay.
You can read. So, Carlo, your neighborhood is a little bit feel disturbed, huh? Because of geopolitical actions.
Yeah, a lot of political issues.
So it's a strange world we are in, at this moment.
Yeah.
But never mind, it shall pass.
Yes. We're living at difficult times, my friend.
Oh, it is, unpredictable. Hi, Arkin.
How are you?
Hello, Arkin.
Thank you. How's it going? Nice to meet you all. Happy New Year.
Happy New Year.
Happy New Year.
So Arkin, what time is it there?
It is 6 o'clock, 6 p.m.
Okay.
It's 1.5 hours from India.
1.5. Yes, we're almost there, 7:30.
8 a.m. here in Mexico.
No.
Yes.
Early in the morning.
Yeah. And it's cold here in Mexico. Right now it's a little bit cold. So it's
Delhi is very cold presently.
So we'll be going live in the next 1 minute.
1 minute, okay. All right.
Okay.
We are prepared. Thank you. Is Nuhu back?
Hi. Yes, I'm back.
Okay.
Good morning, good afternoon, and good evening, esteemed speakers, organizers, and participants from across the globe. I welcome you to the IPA webinar by the IPA subgroup on quality and patient safety, Pediatric Death Audits towards improving quality and safety in pediatric care. So, I'll welcome the first speaker, Dr. Rajesh Mehta, who will give you a brief instructions regarding the webinar. Dr. Rajesh Mehta, MBBS MD, FIAP, is a pediatrician with 44 years experience in newborn child and adolescent health. He is a professor at the Public Health Foundation of India and coordinator, and the subgroup on quality and patient safety coordinator. He retired in 2022 as a regional advisor, WHO CRO, New Delhi, supporting almost 11 countries and led the POCI quality improvement model in the region. Earlier, as a faculty at VMMC and Safdarjung Hospital, he established the SHH and Adolescent Clinic, and he is also a fellow of IAP 2004 and Salzburg Global Fellow. Over to you, Dr. Rajesh.
Thank you. Thank you, Aishwarya, from International Pediatric Association's office. And it's a pleasure for me to welcome all the participants from around the country. So good morning, good afternoon, good evening from where you are, and Happy New Year to everyone. Welcome to this series of webinars of 2026 from Quality and Patient Safety Group of International Pediatric Association. IPA actually gives a high priority to this area of quality and safety since last term. So last 2 years, 3 years also, we had a series of webinars. And this time again, we are starting this year with a series of webinars on this topic of quality and safety. The last one, which we did in September, was around the time of World Patient Safety Day. That was the opening, webinar of this term of Executive Board of IPA. So welcome back. And with this time, we are talking about this on a pediatric death audit and reviews, which will be, very useful for improving quality of care in an ongoing basis in pediatric practice. That means both child and newborn. And also in many countries, same things apply for adolescent health also. So this webinar is actually this time is being live on a YouTube channel also. So many participants would be connected there, and many of them are now live on Zoom. And I see 50 of them already. We have a registration of more than 225 odd participants. So let's see how many can get the benefit. All of you kindly go through these presentations. We have tried to make them pretty much focused on day-to-day practice of pediatricians, and it will be useful for you. If you have any questions arising from these contents or otherwise, you can write your questions in the Q&A feature of this Zoom platform, which is the box is available at the bottom, ribbon of the screen. So write your questions. We will take the questions at the end of the presentations. All of you will be eligible to receive a certificate of participation, but you must have attended the whole duration of today's webinar. And after that, you would be required to fill up a feedback form. And once you submit that feedback form, after attending this whole session, the certificate of participation will be emailed to you pretty soon by the office. And there are Zoom captions which are projected. Many times translation may not be accurate, so be mindful of that. We appreciate your understanding. So let's begin. My pleasure to invite the president-elect of International Pediatric Association, Dr. Carlos Alonso Rivera from Mexico, who is the current president-elect and will take over as president in the next term. And he's a pediatric neurologist with more than 25 years of clinical experience and 30 years of professorship in pediatrics. He founded the Pediatric Neurology Residency Program at the Autonomous University of San Luis Potosi. He has led national and international scientific activities, served as president of SMNP and CONAPME, and currently is president of the Latin America Association of Pediatrics. His research and publications focus on pediatric epilepsy, headaches, and child neurology. So I invite Dr. Carlos Alonso Rivera to give his opening remarks for today's webinar.
Thank you very much, my dear friend. And it's my pleasure, it's an honor to be here with opening remarks to this interesting webinar. From IPA, it's very important to work with all over the pediatricians in the world in different topics. But of course, safety and quality of attention is one of our priorities. So I think this webinar is going to be very useful for all pediatricians interested in this topic. Now, share with your opinion. It's important to interact with us because we need to understand each other, the different ways to attend children all over the world. We understand that it's different in different parts of the world, but we need to understand the differences in these kind of activities. So welcome all, and I'm sure that they're going to be a very successful webinar. Right now, I'd like to introduce our moderator for this interesting webinar. It's my pleasure to introduce Dr. Poonam Gupta. She will be our moderator of this webinar. Dr. Poonam Gupta is a Senior Improvement Advisor. She has a lot of experience in the Foundation Trust London, and he is English Value Improvement Initiative with the Achieving Outstanding Results on Setting a Big Family Adoption. She has a lot of experience in large-scale transformation, focuses on quality, safety, and value across the Middle East and India. Previously, she was program director in the Proven Heart Hospital, Ahmad Medical Corporation, lead the National Efficiency Improvement Collaborative in Saudi, and is a faculty in this Institute of Health. As you can see, she has a lot of experience in that topic, so it's my pleasure to introduce, and I give you the micro to Dr. Poonam Gupta. Welcome, Doctor.
Yeah, thank you so much. Thank you so much for the introduction, Dr. Carlos, and good afternoon, everyone, and a very warm welcome to this session today. So I really feel privileged that I'm going to moderate this session today. I'm really delighted. Just a brief about this topic, why I feel that this is really a very important topic today for the discussion. So improving the quality of pediatric care, it requires more than the clinical expertise alone. It depends on strong healthcare system, effective service delivery, and consistent adherence to the national standard of care. But despite of our best efforts, pediatric deaths, they still occur. And each one represent not only a profound loss for the families, but also a critical opportunity for learning. So the pediatric death audits and reviews, they allow our healthcare teams and systems to pause, reflect, and ask an essential question. Could this death have been prevented? So by systematically examining the circumstances and contributing factors, surely we can identify the gaps in timely manner, and evidence-based interventions can be implemented so that in future this kind of events or incidences can be prevented. But when it is this kind of audits, when the pediatric death audits or any mortality audits, when it is conducted in a structured, non-blaming and honest manner, they become a very powerful tool for improvement. They inform the changes at facility level and guide reforms at district, state and the national levels. So in today's session, we are going to explore both the global guidance and the real-world implementation of pediatric death audits. And we are going to highlight how this approach can translate learning into action and improve the outcomes for children. So I'm delighted to, it's my great pleasure to introduce our very first speaker, Dr. Nuhu from World Health Organization. So Dr. Nuhu is with us, and this is a brief intro for Dr. Nuhu. He's a medical officer in Department of Sexual, Reproductive, Maternal, Child and Adolescent Health and Aging at WHO headquarters. His work focuses on strengthening the healthcare system and improving the quality of maternal, newborn and child health services. He leads WHO's work on early child development and quality of care across the life course and coordinates the development of global normative guidelines and tools to improve child health services. In the context of pediatric death audits, he supports countries to adapt WHO guidance to national context and integrate it into existing national mechanism to strengthen learning, accountability, and quality of care for children. So, Dr. Nuhu, welcome on this forum, and over to you with the presentation. Thank you.
Thank you very much. Good afternoon, good morning, good evening to everyone, and grateful, Dr. Poonam, for that very kind introduction. So I'll be making a presentation really focused on the WHO pediatric, as Dr. Poonam said, talking about the Pediatric Death Audits and Review Guide. And I really hope you can, my part of the presentation is the boring part. My colleague, Dr. Wendy, will be presenting a very interesting part about the real world applications. So I'll start off by basically this presentation is really, we have just about 25 minutes, so that's really too short to go through the guide, but I'll do my best really to highlight the key areas of the guide and how it's related, can improve quality of care. Thank you. So this is my outline. I'll really be focusing on broadly of mortality reviews and quality of care, then go through the guide itself and just highlight a few slides from best practice for implementation. This will be brief because we will actually have a full presentation looking at the experience from Indonesia. So as you know, there's been substantial progress that has been made in reducing child deaths globally since 1990. However, still many preventable deaths still occur, and a number of them are due to poor quality of care and adverse social and environmental circumstances. It's, as Dr. Poonam says, quite tragic whenever a child dies. And it's all doubly sad also for healthcare workers who have been caring for the child. And however, we do know that yet when children, although there's been an increasing number of children accessing care, a huge number of them still do not meet the minimum standards of care. We know that up to sometimes in some contexts, 54% of children experience at least one adverse event. And when various research have showed that in some places, children are only getting about a third of clinical actions that they're meant to get when they see a healthcare worker. And this is just highlighting now that overall, we are now seeing more deaths from poor quality of care compared to total deaths, particularly compared to inaccess to care, particularly in low and middle income countries. So this is a concern. And for WHO, this is important because, particularly for maternal newborn child health, we have a vision of ensuring that every woman, newborn child, and adolescent has quality care throughout the continuum of care of their life course and for each level of care. And this is aligned with the Sustainable Development Goals, the Global Strategy for Women and Children's Health. And it should also include not only provision of care, but also experience of care. And we have a number from WHO for child health. We have looked at across the life course from community up to hospital care. We have developed a number of practice guidelines, standards, and also guidances which cover clinical practice care, looking at health system environment, standardized clinical care, aiming to reduce harm, guides that address point of care quality improvement, and also guides that highlight how to engage the patient, family, and community engagement. So we have a lot of these practice guides, and yet we still see that care is often not meeting standard. So what is pediatric death audits and review? So first is what is morbidity and mortality audit and review? Broadly, it's a quality of improvement process that seeks to improve patient care and outcomes through systemic review of care against explicit standards of care and the implementation of change. And really, it's usually triggered by an event, in many cases a death, but it could also be by a highly unusual case. And what happens really is that you look at what care, in this case, the child has received and compared to care provided against the criteria and standards of care. And the idea is to identify the gaps and develop recommendations and action plan. This is not, for child health, this is not new. It began in the United States in the 1970s. And in many countries, even in low income countries, it's now a statutory part of requirements in many countries, where you have to do mortality audits to initiate improvements. And the objective is really to make sure that patient care is consistent with best practices. And the idea is to look at what really happens with what should happen and improve care. So in terms of pediatric audit review and improving quality of care, the linkages to quality of care are quite clear. it's important for improving quality of care, particularly in hospitals and facility level, but also at facility level. And really, through this slide, you can see summarizes how pediatric death audits and review can improve quality of care, because it allows us to see the system gaps in how children move through our wards, whether it's from triage, diagnosis, treatment, referral, and monitoring, by reviewing real cases. And the teams can strengthen adherence to clinical guidance and improve documentation and referral practice. Just as importantly, a huge aspect of it is reducing the blame. So it's really so part of what makes pediatric death audit review is ensuring that all of this is done in a blame-free culture that accentuates and ensures that the data that is generated supports better planning and accountability. So improvements are made based on evidence rather than opinion. So basically, what's the WHO operational guide? It really provides guidance on establishing establishing a national and facility system for health facility-based pediatric mortality audits review and case review. And it really, the reason for that is that all health facilities usually that care for children, especially hospitals, should have an effective system for death reviews. This has not been seen. And one of the impetus for this guide is because often the reasons are that there's a lack of time, there's a high burden, there are a large number of child deaths. So what this guide is trying to really do is how to, it's a way of not only taking into context the practice itself, but also serving as a way of improving the overall system to address these barriers. And the focus here is on facility-based audits and is built on the principles of confidentiality, multidisciplinary teamwork, and systems thinking. And as you will see, it's really structured around the key steps of the audits cycle. So the outline of the guide, really, if you had the guide, and I'll show the link at the end, really, it's really outlined along establishing subnational national systems, how to also set up in the health facility level, then also how to conduct the audit itself. And then really it has also examples and samples of forms that already you can take directly from the guide to adapt to your setting. So it's really a way of like starting from the facility level to strengthen the overall national health system. So the first step usually is getting at the facility level is setting up the pediatric audit team. And this is important so that there are clarity in function, clarity in processes, and clarity on who are the members of the team. And once this team has been selected, the focus is on the clinical pathway to identify the cases for review, prepare case summaries, and conduct initial case analysis, and organize. In addition to that, the tone must be confidential and blame-free so that people can be honest about what actually happened. So basically, in addition, the team will select a chair who will be responsible for organizing these meetings, whether they are at weekly level or monthly level. And really the chair is to set the tone to ensure that it's blame-free. And an output of this is the documentation of findings and recommendations and who is responsible for follow-up of implementation of the agreed actions. So in terms of thinking what needs to get started, for this to work in real clinical practice, there has to be training in audits and not necessarily extensive or very long training. This is, as me and my colleague will show, this is really short trainings that focus on how to quickly get started up. And it's a clinical mentorship approach to training, which builds on system thinking and quality improvements. And then identifying and agreeing on what are the standard forms that will be used for analysis, and then how you define deaths and identification of deaths so that there's a consistency across all meetings. Then finally, the meetings have to be routine, as I said previously, whether they're weekly or monthly, that will be determined by the caseloads. And then having a system where all of what is discussed can be properly recorded and stored. So this is the core step at the facility level in terms of the death audits, which is the 6 steps, which is identifying cases, collecting information, and then analyzing, recommending, implementing change, and monitoring evaluation, and going over again that whole process. So in the first step, the first step is really simply to remind us that which deaths enter into the review. And usually, although not all deaths will be reviewed, depending on the caseload, all deaths need to be recorded, and there has to be a focal person has to, for the pediatric death audit review team, has to be notified within 24 hours, and all deaths recorded in the facility registry. And even though not all deaths will go through the in-depth review process, a summary has to be presented at each review meeting. And from there, a select number is selected. And there are a number of criteria different institutions can use, whether it's unexpected deaths, a death that should not have resulted from a condition that should not have resulted in deaths, or a death following a surgical process, or a death where the staff or family have raised concern. Practically, my colleague Dr. Windy will show how some of that has been done, what is criteria in Indonesia. Followed by the next step is really collecting information, and this you need standardized data collection tools to ensure that all information is needed is collected, both clinical and contextual. And the information is extracted from whether it's the clinical charts, the triage records, drug charts, and when needed, also you have information that's collected from the parents or caregivers, or even from for example, the referral services, or with the ambulance or healthcare workers who referred the patients. And the key elements is what is the presenting condition, what is the assessment treatment provided, and recording the timeline of events that happened prior to death. And so this is an example of the child and neonatal death review form that is in the guide. So after this, the next is analyzing the information, where the aim is to support the team to have a constructive discussion. The aim is not judgment, as I've said, and the 3 steps are: 1, identifying the cause of death, and that identifying the cause of death, usually you follow the ICD level classification, and then it's the sequence of events that led to that, and the modifiable factors, which I'll discuss in the next slide, which is quite the most important step in this, in the audit cycle. So using standardized diagnosis criteria, you classify the cause of death, and then at this point, you will do a basic root cause analysis of what happened, why did the child die, and what happened along the sequence of events that led to death. So now, the most important output is this, what we've called the modifiable factor. And it's really, modifiable factors are points in the care pathway that could reasonably have been changed and could have prevented deaths. So that's really important. The idea is that if there had been practical improvements, that would not have occurred. And it's the reason why we've said modifiable and not avoidable substandard is to actually address the issues around blame, because once you use the word avoidable substandard, it can lead to people a blame attached to an individual. And modifiable factor, when you're doing this, when you want to classify and look at all levels of the health system to see where the modifiable factors, because there could be numerous modifiable factors, one at the home and the community, which could include even like things like looking at the social and environmental factors like a poor wash or poor nutrition, then looking at what happened at when the child first sought care, whether it's at the primary care level or other levels of the healthcare system, and then what happened at the level of once the child was in the hospital. Looking at and going through this, you're able to identify in a child, there might be just one modifiable factor, but often there are multiple factors that could have been, that have contributed to the pathway, the end point, the unfortunate tragic outcome. So the idea is that the modifiable factors are the factors that the facility or the team will try to seek to change and use that as the way of improving not only patient safety, but also improving quality of care. So once you identify the modifiable factor from the timeline, you go to the next step, which is recommending solutions. And this is really turning, for each factor, modifiable factor, there has to be concrete solutions. And here, depending on what the factor is, it could be a short-term, medium-term, or long-term. We have to identify, and in that, look using the quality improvement language, the objective when thinking about the actions has to be SMART. So it has to be specific, measurable, action-oriented, realistic, and time-bound, and document who will do it. And at this point also, usually for modifiable, at this point, you also ensure that who are the decision makers that will need to be involved so to ensure that this is corrected. And so this is an example of an action plan summary form. You can see that on the left is the practice to be improved. And so that's the modifiable factor, then what action is to be taken. And then where is the action to be taken, deadline, who is responsible, and action. And at the end, at the monitoring evaluation, looking at, and which is the final steps in the audit cycle, is looking at has the action been taken and what has been the outcome. So in implementing change, the change, and this is where we will come to see how this links with overall broader quality of care teams in the hospital is that, or in the health facility, is that any change has to be integrated into routine ward activities, staffing patterns, and procurement systems. So, and the senior leadership needs to support this process by providing resources needed. Some of this can include continued professional development, improved communication, but the whole emphasis is that it's really sometimes implementation we should also not only be looking at that, we should also be celebrating success where necessary and where it has been attained, particularly once a change has been implemented and the outcome is seen. Finally, as I said, we need to complete the cycle. You need to be thinking about what actions have been implemented. For those that have been implemented, what are the outcomes? And for actions that were not implemented, understanding the reason why. Some indicators that can be used include trends like delay in treatment, case fatality trend, time to treatment, availability of key commodities, but also obtaining feedback not only from staff and managers, but also patients and caregivers. So at this point, and this goes through for every meeting, looking at the end of the meeting, once you develop all your action plan, at the next meeting, or depending on how long, keep following up of what were the agreed recommended actions to be taken. So this is and this is just trying to show the linkages between the audit cycle, which is on the left, the 6-step audit, and usually, and Dr. Windy is going to show this, showing how you can integrate pediatric death audits and review into QI, and using QI methodology to test changes. So these are examples of the forms that can be found and downloaded from the guide or adapted for practice, including using common ICD classifications for common causes of morbidity and mortality in children, particularly in low and middle income countries, examples of registers that can be adapted for the recording death registers, and also then examples of review forms and action plans. So all of these are available on the guide and can be adapted. Usually when we work with countries, we see that this is usually the starting point, and then countries compare to what data they're already collecting in their system or within their health information systems and adapts to fit. So to make pediatric audit and review truly work, it must be embedded in the national system. And so this is just moving from the facility to looking at a whole system change. And so it needs clear leadership and ownership from the Ministry of Health and professional bodies. So in this case, IPA has been, in many countries, IPA has been a good partner where we have engaged early. And this must be supported by policies and governance structures and an enabling legal and ethical framework so that staff can feel safe. And the system is also national guidelines and some SOPs and tools are also needed, that all so that languages used in different can be comparable across facilities, as well as necessarily is a strong documentation system, ICD-based coding, but also a strong health information system. There has to be also committees which can be integrated with existing like NPDSL committees or broad quality of care committees. And so that will depend on the country situation and obviously ongoing support for whether it's training. And once this is happened, once these functions are in place, the system can then perform its core function, which includes good standard documentation, record keeping, ensuring the legal safeguards are in place, supporting health facilities to carry out regular review meetings, and then also crucially supporting from the national level downwards, support the implementation of recommendation and the QI action. So I just wanted to highlight a few best practice from clinical implementation, best practice for implementation, particularly in the audience. And one is, as pediatricians, there is a leadership role for pediatricians, particularly in this. As I said, in many countries, pediatricians, the IP has been has helped in terms of helping to take implementation forward, and because of its mandate. But so pediatricians can serve as champions for audit and leadership. They set the tone, providing. Then pediatricians obviously should actively participate, whether it's leading or being part of review committees, but also providing clinical expertise, particularly in the lowest level facilities, and also ensuring that reviews are actually constructive based and not blame-fueled, and then ensuring that documentation certification is taking place. Crucially, I think one role where we've seen IP support and leadership has been in ensuring mentorship and training in how to carry out pediatric death audits and reviews, particularly for non-clinicians who are also part of the process, and also constant advocacy and sustainability. So this is an example from a country where the idea, it started small and there was a build up, and really it started with the review of WHO training materials and from a bottom-up approach, we're looking at what already existed. So in this country, we saw that they had already standardized charts, which were already developed from a broad QI process that were taking place. So the key was around engagement of senior leadership of Ministry of Health, engagement of child health partners. And then there was a selection of some pilots in some facilities to basically see how the concept of conducting CDA training can be implemented in that setting. And there wasn't really a huge focus on lots of form filling or anything. It was really around mentorship, documentation, around its quality improvement. So in this place, there was less, the stats was more around starting quickly and quality improvement, and then moving backwards towards documentation. Then in terms of organizing at national level, I think this is an example from Nigeria. And in Nigeria, what has happened is that because already in Nigeria, there's a massive NPDSL structure that's already in place at both national and subnational level. And there's also from the quality of care network, there's also quality of care processes and bodies at both national, subnational facility level. What is happening is that the linkage has been to include, pediatric death audits and review into the NPDSL structure, so that at subnational level, at the state level, the child pediatrician has been included in this committee that's interacting with the quality of care working group. And then at facility level, there are two teams that in addition to the quality of care team and the existing NPDSL team, there is also a pediatric death audit and review team. So both of these teams together in the states, in bigger facilities, they are different teams, but in smaller facilities, they are combined. But the idea is that both of these committees work in collaboration with each other at all levels of the health system. So as I finish, I just want to highlight some of the guides existing from WHO around strengthening and improving quality of care and patient safety. We have the standards for improving the quality of care, which really looks at how care should be provided, both from provision of care and also the experience of care, thinking about how caregivers should be treated, how children should be treated, ensuring that their rights are respected. We have the guide, which I've run through. We have the pocketbook for hospital care which we're in the process of updating. We'll be releasing a new edition in the first half of this year, the 3rd edition. And then we have obviously the IMCI chat booklet for primary care level, which will also be updating in the next 2 months. And then in addition to that, we also have the pediatric assessment trial, critical care for ill children, which again, we are updating. And then working together with our colleagues in WHO Sierra region, they have done a lot of work around point of care quality of improvement for maternal, newborn, child health, which is also a very good, useful tool for quality of care. So in conclusion, you can, maybe I'll leave this for a minute on the screen so that you can use, through this QR code, you can access the guides. But really, what I hope I've highlighted, but which Dr. Windy will show more clearly in a real way, is that PDA is a structured and blame-free cycle for learning from death, unfortunately, when that occurs. And we can use it to drive measurable improvements in care quality and also patient safety. And we can integrate into locally valued clinical practice so that PDA can affect change in the form of local culture shift and quality improvements. And then most countries, it's very important to have standardized tools and guides. And lastly, this will only work when there is a blame, when it's created in a culture where people feel free to be able to share what has really happened. And so the aim is not to blame, but the aim is to improve the quality of care that the child receives. Thank you very much. So I'll leave this for maybe 20 seconds in case people want to scan the QR code to download before I stop sharing. Thank you very much. So the next speaker, as I said, is my colleague, Dr. Windy. She's from Indonesia. And next slide, please. So Dr. Windy Krishnawati is a pediatrician at the Gatot Subroto Military Hospital. We've worked extensively with her. She's a huge experience person with extensive experience in maternal and child health quality improvement. She has served as an MPDS and quality improvement facilitator for the Ministry of Health of Indonesia and is a quality improvement consultant specializing in neonatal health with UNICEF Papua, but also with WHO, working with us at the global level and also in the Eastern and Mediterranean region. Her work focuses on strengthening health systems and improving outcomes for newborn and children. So Dr. Windy, over to you.
Thank you for introduction, Dr. Nuhu. So let me share my slide. But before I start the presentations, please help me for the polling. Kindly, the participant can, excuse me, can somebody help us for the polling? Yes, thank you. Please, please fill the answers with the closest one with your conditions in your hospital, in your healthcare systems. Do you conduct the mortality and audit routinely in your healthcare facility? No, or only conduct the audit when there is a potential medical legal issues, or only conducted medical or clinical audit? Only implemented NPDSR and PDAR approach, or implement the MPDSR or PDAR and QI method? Okay, if everybody has voted, please share the answers.
So participants, Dr. Windy is requesting that if you can vote for one best option you feel applies to your hospital or the health system where you work in your countries. So kindly select the best option. You have 60 minutes to complete this exercise. Thank you for your cooperation.
If any participants has filled the answers, so we can look at the whole answers?
Yes, so we'll end the poll in the next 10 seconds
Yes.
and the results will be visible. Yeah.
Okay.
Yeah,
Most of
so
the answers
yeah.
have conducted the medical or clinical audit, and it's only 13% that implemented the MPDSR and QI method, and thank you for your answers. So I will share about our experience from Indonesia to implement the death case audit in facility level. Indonesia is a large country, so we have 3,000 of hospitals and 280 millions of people. So we have a lot of various facility level among province. And this is a various number of infant mortality rate is in Indonesia across 38 countries, provinces. And the high infant mortality rate in Indonesia is East Indonesia, is Papua, West Papua, and Maluku. When look at a big picture of contributing factors to high infant mortality rate is low quality human resources, geographical challenges, poor communications facility, limited electricity supply. So it not related to our role as pediatricians. But when we take a look more clearer in the facility level, regardless of the national level problems, what is truly occurring at the facility level? In recent study and recent data from the Ministry of Health, most of the death case occur in the facility level. Over 20 years, the audit meeting implemented in national and subnational level, but nothing significant change in reduction of child mortality. So when we talk about facility level, we talk about our responsibility as pediatricians to reduce child mortality. This is consistent with the other data and what Nuhu has presented before about poor quality of care that has significant effect to child mortality. The success of universal health coverage is not significant role to reduce mortality because the poor of quality of health care. So Indonesia start to have a system online to report the MPDSR and child mortality in Indonesia. And we began the pilot study with a partnership in Indonesia Pediatric Society, OBGYN, and Gatot Subroto Military Hospital. So this is the pilot study to select some of hospital to include in this pilot study. The rationale for the hospital selections is to allow scaling up to the network hospital at the subnational level. But when we took a look at the barriers for implementing that case review in our pilot study, is a difficulty to recommendations and difficulty to result the robust solutions. It's most of the death case is underreported and very poor quality of documentation and reporting. And also very difficult to establish ICD-10 accurately for the cause of death. Dr. Nuhu has explained about the 6 steps of the audit and review cycles. Most of the facility level stop the cycle in the step 3. Only establish the audit meeting, discuss the cases, and it's done. Several to the next step, several facility to the next step in recommending solutions, but nothing happened after that. And only small amount that the facility level go through to the implementing changes. But most of the recommendations is for external factors, the recommendation for the government, for healthcare officer, for hospital management. That it's important to use QI for every unit in facility level. So what is the role of pediatricians? The pediatricians is the most expert individual. The pediatrician has strong pathophysiological understanding, has solid understanding of disease. So pediatrician should determine the pediatric cause of death. Indonesia used the medical certification of cause of death with MCCD approach from WHO. When we review this PDAR approach, we can see 3 cause of death that state it acute, chronic, and environmental and social contributing factor for the cause of death. But Indonesia used the MCCD approach from WHO that divide the cause of death into different cause of death. The first is terminal cause of death. We usually use the direct cause of death or immediate cause of death due to underlying cause of death. Example, when a child dies due to hypovolemic shock, the hypovolemic shock due to acute diarrhea. So the terminal cause of death is hypovolemic shock, and the underlying disease is acute diarrhea. It could be a different purposes. The terminal cause of death focus on healthcare facilities. How the management of hypovolemic shock in the ER? Is fluid resuscitation available? Is intravenous administration timely? Is the volume of fluid resuscitations is aligned to the guideline? But in the higher level, we should evaluate about acute diarrhea. How about the rotavirus vaccination coverage? How about the water, sanitations, and hygiene program? So when we use the MCCD approach, we can define the more broader of solution. The next role of the pediatricians is to define the modifiable factors in preventable death and can prevent the death and doing gap analysis. Most of the doctors knows about medical audit. When we are in the faculty of medicine, we used to have audit meeting for the death case audit with medical audit approach. What the difference between the MPDSR and medical audit? Let's say these patients died due to hypovolemic shock. In the medical audit meeting, we evaluate how the doctor treat the patients in the ER. Is it aligned to the guideline? If it's yes, the case was closed. In clinical audit meeting, we evaluate the team and the response of the hospital, the nurses, the pharmacists, the doctors, and the teamwork. Is it aligned with the clinical pathway? If it's yes, and the case closed. How about the PDAR? The same patient and the same case, from history taking, we found that 3 days earlier, these patients visited the private clinic with diarrhea and only given probiotics without oral rehydration solutions. And the parents did not get educations about the emergency symptoms. And when the child has dehydrations, they came to the primary health clinic, and during the transportation, he didn't receive a fluid resuscitations because of lack of the fluid resuscitation or ringer lactate solutions or infusions of fluid. So the PDAR meeting or the audit meeting is not closed because we have to result in recommendation for multiple stakeholders. So in the PDAR meeting, modifiable factors is beyond clinical or medical issue. The second one is, in audit meeting, the pediatrician should do the gap analysis. We should evaluate how far that what really happened to these patients, what should happen according to the guidelines. What should happen in the private clinic when acute diarrhea patients came to the doctors? What happened to the primary healthcare when dehydration patient came to the PHC? So what we need to do the gap analysis more valuable and significant for audit, we have to know what the guideline. So if we practice gap analysis more and more in audit meeting, we can be a better clinician because we have to learn the best evidence-based medicine. And what next? The next of audit meeting is to narrowing the gap between what really happened and what should happen. This can improve the quality of care and through the quality improvement method. Several quality improvement methods are available for implementation, but I think the suitable one to link with the MPDSR approach is a point of care quality improvement. And you know, Dr. Rajesh is one of the writer to develop this module. Maybe you can ask him about all these modules. So the challenges and the barriers in facility levels is various. Also, the blaming culture still exists. So we would not provide a transparent and a truth of the information of the patients because the audit meeting seems like a judgment day for the healthcare workers. And sometimes the medical summaries are very poor quality. We do not write or the patient's experience or patient's vital sign. And the lack of knowledge of the standard of care, Dr. Nuhu has shared which guideline we can use for to evaluate whether we do the good standard to optimal practice. And the recommendation focus and address the external factor, not fundamental issue, but it's only reactive. As the example is when we found the asphyxia-related death, it's common for us to recommend procurement of ventilator, mechanical ventilator. But only small of us that ask why the patient asphyxia. So it's very shallow for recommendations. It's not specific if we don't have root cause analysis process in our audit meeting. So this is the reflections for us. How often do you find this statement in audit meeting? Do you think it's normal when a patient presents in severe condition and they die? Do you think it's unpreventable if we found the death on arrival patient? And do you think it's necessary to attending physician to present the death case? Or do you think it's a misfortune or unlucky event is if patients have the incidents, several incidents? So sometimes in our audit meeting, there is a Swiss cheese phenomenon. The minor error has been neglected time over time. But when the minor error stand alone in isolation, maybe it's not fatal. It not become a death case. But when the minor error occur in sequences after one another, it could become a death case. So this is not misfortune or fate, only a failure of safety net settings. So if this discussion occurs in your audit meeting, please improve your audit meeting quality. The reflection too, how often do you find these recommendations in audit meeting? Okay, we need more pediatrician, we need nurses, one patient with one nurse. We need super specialists. We need more medical equipment. We need more bed in ICU. We need to build a microbiology laboratories. We need certification and large-scale training. If yes, if you often find this in your recommendation, you need to learn QI. I don't say that ventilator is unnecessary, but we must focus on something simple that we have to do in the short time for QI, rather than procurement of medical equipment that's very need a lot of budget. So this is consistent with the recent study that large-scale training workshop alone didn't have a significant effect to improve quality of care. Some of training workshop resulted in one piece of certificate, but when the participants go back to their workplace, nothing happened. So this data showed us that quality improvement should be linked with all the training in medical field. What about QI? QI is its management approach to reorganize your care to the patients, so the patients receive more valuable quality of care. Without QI, many solutions focus on the outcome, do not target the root cause. In this step of QI, in the step 2, we analyze the problem and measuring quality of care, and we do the root cause analysis. As simple as we asking why. The asphyxia related that why the patients get asphyxia, because the meconium in the amniotic fluid is aspirate from to the lungs. Why the babies aspirate the meconium stain in amniotic fluid? Because the baby's fetal distress. Why fetal distress? Because nobody evaluate the fetal heart rate. Why the midwives didn't follow up the fetal heart rate? Because they didn't use the partograph as is it to the guideline. So despite a procurement of mechanical ventilators, it's important to follow up the fetal distress before asphyxia is occurred. This is the lesson learned from Biak Hospital in Papua. The first intervention is to identify why the leading cause of death, why the babies is die. The high rate of asphyxia-related mortality was identified. Do you notice the infection rate is very low? The infection rate is very low, not because the infection control is good, because the neonatal was dead before 24 hours of life, before the infection has developed. So in the first our QI journey, the asphyxia is the topic to be in our QI interventions. The procurement of medical equipment, we do it in the 4th years because the first of our program is neonatal resuscitation drilling. We do it every day to train the first golden minute for every nurse and the midwives. And every week, we're doing mega code to do the teamwork to the resuscitation team. And this is graph illustrate that the QI collaborative with primary healthcare, and the healthcare officer is the best QI and has lowest mortality rate. Sometimes when we hear about limited resources hospital, we said it's acceptable for the babies die because limited resources, limited pediatricians, and limited medical equipment. But this lesson learned show us that with simple step of QI method but consistent, we can reduce the mortality. The other lesson learned is the point of care approach. In the neonatal unit in tertiary NICU in Gatot Subroto Hospital, this approach linked to the MPDESR program. Sometimes we said in the tertiary NICU, the complexity of the disease, the severity of the disease is acceptable to die. But when we can look what we have to do, we can link the MPDSR approach with POCI approach. What we can learn in the audit meeting. First, we identify, is it the case preventable death or not? When we said it preventable, we have to find the modifiable factors. But the modifiable factors, we have to see the root cause of the modifiable factors itself. So we can result in recommendation with SMART approach, specific, measurable, achievable, relevant, and timely. The next step of audit meeting is POCI approach. We setting priorities. We introduce change of ideas based on the root cause analysis and do the plan, do, study, action cycle. I really love this prioritization matrix because without this prioritization matrix, sometimes we dream too high. This delay of treatment due to the geographical constraint. So we cannot change the mountain or the weather because we're not God. This is because of the national policy. We cannot change the national policy. We are not Ministry of Health. We are pediatricians. So find something, the change of ideas that under control by me, under control by pediatricians. Define the importance of your recommendations and choose the affordable one. And choose some program that very easy to be measured. You have to define what the process and what the outcome, what the indicator of the process and what the indicator of the outcome. So this is showed how we have a PDSR, plan, do, study, act, RAM for 3 years in Gatot Subroto NICU. In the first year of implementing MPDSR, we identified that the very high mortality in newborn due to infections. So all the program, all the QI project focus on the infection control. You can see this is the topic that we implement in our unit to reduce the septicemia and reduce the neonatal mortality. After 3 years of QI journey, the preventable death decreased from 83% to 40%, and the last half years is 16%. And most cause of death shifting from the infection to congenital anomaly. This graph shows the additional effect after MPDSR and POCI implementation. If you notice, only infection-related program that we implementing in our QI journey. All the change of ideas focus on infection control. But the same spirit applied on the other field. We have the spirit to speak more about patient safety. We have the spirit to align our quality of care with the standard. we have the spirit to minimize the gap between our service and the standard and the guideline. So, although the focus of intervention is the infection control, but overall healthcare system is improved. We can see the healthcare worker skill is improving, and we can treat effectively more patients over time. Improve quality and quantity of service, along with increased awareness and commitment to patient safety, which are also experienced by patients, but other patients who did not die, especially patients with extremely low birth weight, because our focus to reduce septicemia, not to reduce the cause of death due to preterm, but in our data, the survival rate of extremely preterm babies is also increased due to MPDSR and QI approach. And what have we learned from the MPDSR? We have the same spirit because there is no individual error. It's only system failure. So when we do something wrong, we have to speak because we have to evaluate the system. Why I did the wrong to the patients? Why I make incidents? Why we have the near miss or we have the medical incidents? We want to speak up for patient safety, and it's built intimate with the team engagement. This is lesson learned from East Nusa Tenggara District Hospital. 19 death cases were audited. The most leading cause of death were asphyxia and septicemia. This is the recommendation result from audit meeting. Procurement of mechanical ventilator, procurement of echocardiography mobile machine, and develop microbiology laboratories to perform blood culture. Provide antibiotics from reserve category, such as carbapenem. After introducing of QI, this is the recommendations. The same cases were analyzed, the same cases were discussed, but the different recommendations was resulted from the different audit. Increase hand hygiene compliance, improve stabilization monitoring, enhance capability for first golden minute to prevent meconium aspiration syndrome, and early detection of fetal distress through fetal heart rate monitoring. Can you notice the difference between the two recommendations with the same cases were analyzed, but one before QI was introduced and after QI was introduced? When the recommendation result in these sections, what did the pediatricians do? Only wait, do nothing. Wait for the budgeting, wait for the mechanical ventilator to be bought from the hospital management, wait for the echo machine come to the hospital, wait for the microbiology laboratory established in the hospital, and wait for the antibiotics. The pharmacist will provide it, not the pediatricians. So when the pediatricians recommend this solution, they do nothing after the audit meeting. But after QI approach was introduced, something changes. This is the team project. Pediatricians and neonatal nurse and the midwives and the OBGYN team. Can you see the difference? Something happened with the small step and simple recommendations. This is the lesson learned from Papua Highland. Papua Highland is categorized as a red zone from United Nations Department of Security and Safety. So there is no pediatricians work there, and the recommendation from the audit meetings is the same over the years. We need a pediatricians And we need the political issue stabilized. They believe that if there is no pediatricians, if the conflict and the politics remain the same, it's impossible to reduce the mortality rate. They believe of that. But the recommendation after QI training for 2 days, the same cases were analyzed. You can see this is the recommendation. Okay, we only have general physicians here. We have 4 GPs, general physicians in this hospital, and the leading cause of death is tropical infections, including malaria, tuberculosis, and the second one is severe malnutrition. And we take a look at the data and do the gap analysis. It's a wide gap between the standard and what happened to the patients in the field. So we introduced the hospital care for children, and they evaluate for a half day. They try to learn about the standard, how to manage and treat the tuberculosis, pneumonia, malaria, acute diarrhea, hypovolemic shock, and they try to make a gap analysis. And the recommendation is a different. The general physicians allocated themselves. 1 GP learn about malaria and tuberculosis. 1 GP focus on malnutrition. 1 GP focus on pneumonia and diarrhea. And 1 GP focus on neonatal health. So it's very different. For the last our mentoring to the Papua Highland, they don't complaining again about when pediatrician will come and work in this hospital. They'll talk about how can we improve the standard? How can we improve to identify the severe of malaria? How can we improve to treat the cerebral malaria? How can we improve to diagnose the meningitis of tuberculosis? So can you see the difference between only discussing the case and before and after the QI approach were introduced? So being part of reducing mortality is beyond curing a disease. Being a clinician is not enough. Thank you for the opportunity. Over to you, Dr. Poonam, to lead the Q&A
Thank you so
section.
much. Thank you so much, Dr. Wendy and Dr. Nuhu, for this insightful presentation. So we really got so much information and knowledge from your experience and the real life implementation of those guidelines. So Dr. Nuhu's presentation, it taught us about what actually the guidelines are, evidence-based practices. And one of the important thing, what I like when Dr. Nuhu, he said that not blaming, the blame culture should be taken away. We should say modifiable factors, not to blame the individual and all. And then the 6-step framework, but Dr. Windy's presentation, it taught us like the framework and guidelines, they are already in place, but what we can do in order to implement this on the real world, and then just see how much impact it has, like before QI and after QI, the vibe in the room has changed. The before QI, the audit, the same audit team, they are saying we need more resources, we need more professionals, we need more equipments, but just after QI implementation, the like whatever we have, what are the things we can use them more efficiently and effectively. Now they are more talking about, instead of 5-step of hand hygiene, let's start doing 6 moments of hand hygiene. So thank you so much, Dr. Wendy. And we have couple of questions from our audience, and few of them they are already being answered by Dr. Nuhu. So, but I really like the answer, so I'll just go with here. So, how to avoid the blame language? This was one of the question from Mariam, and Dr. Nuhu he has kindly answered that. Try to decenter the person, individual from the action. For example, if rather than the doctor on call did not give antibiotic, just say that documentation of events can be like antibiotics were delayed. So our language should we should defocus from individual blame to more, it should be like system process, not the individual. So there is one more question. There are a couple of more questions. There is one question from Shalu Gupta. Kindly highlight some example of death audits from pediatric population and their final outcome. Would you like to address this one, Dr. Bindi?
I think Shalu has observed that a lot of examples were from neonatal or perinatal care. So, Windy, if you have some example directly from pediatric ward kind of situation.
Yeah, actually Indonesia just started pediatric audit and just start to input to the IMPDN system. The IMPDN system is to report the death notifications. Start with maternal, perinatal, neonatal, and now pediatric in just 1 year. So we don't have a robust data and recent data for the pediatric. But in our experience in Gatot Subroto, we just use a simple QI to identify the early warning system in the pediatric wards. Only early warning system has been implemented, and we can prevent the death before, because sometimes we just found the severe or the terminal the critical illness for the patients in pediatric wards. So it's have a delay to transfer to the ICU. But in the whole data, we don't have it.
Okay.
So can I answer the blaming culture? Yeah. We usually use just culture. Maybe you have to learn about just culture. You can browse it and Googling it, just culture. We divide people in the 3 groups. At risk behavior. If someone don't use a seat belt because they don't know what the use of the seat belt when driving a cars, we have to train and give them information. Do you know how important the seat belt for you? Oh, I don't know. Okay, I will use the seat belt. At risk behavior. So don't blame the person. The second one is human error. Oh my God, I know it's important for me, but I forgot to use the helmet. Maybe I forgot to put the seat belt. Human error, you have to evaluate the SOP. You have to evaluate all the system. And the third people is reckless behavior. Maybe you have to stop it, to stop them to be healthcare workers. But the first of all, if you have a incident, a medical incident, find the system failure. That's all I'm doing in our hospital, because in my experience, nurse came to me and said, I administered furosemide, the diuretics, twice to these patients. Why? Because the morning shift nurse didn't do the handover to the next shift. So the handover only state we have administered the drugs, but it's not state antibiotics or diuretics or aminophylline or what drugs. So they give the furosemide twice, and the patient's hypovolemic shock, and it's a near miss or not death. But why they come to me and tell the medical incidents? Because they know the system will be evaluated, not the person will blame. So maybe it's our experience.
Yeah, thank you. Thank you so much, Dr. Vin. It's really useful. And yeah, we all learned a lot because every one of us somehow we face the blame culture. So now we have a second question, and I think this is also important. Dr. Saurav is asking, like, how to handle clinician ego and channelize into a conducive audit finding utilization. So do you face any of this kind of issue, and then how do you handle it?
Yes, sometimes when you have higher educations, you have more ego. Do you know the compliance, the hand hygiene compliance, the highest is the nurse and the junior staff, not senior staff, not the professors, of not the highest educational level. I don't know, maybe it's related to ego. But when we talk about the death case in audit meeting, we talk about system. We don't talk about you, it's the system. When you don't have ability to treat the patients, when you don't have ability to take care of the patients, it's the system failure. Why? The management put you in the ICU. You should be trained before you work in the NICU ward. So all is the system failure. So we talk about the system, we don't talk about us.
Yeah, thank you. Yeah, thank you so much, Dr. Vindi. It is helpful, really. We are running out of time and we have a couple of more questions in the chat. So if it's possible, our speakers can answer to these questions in writing and all, if that's okay. And with that, I would like to invite Dr. Rajesh for the closing remarks.
Yeah, thank you. So looking at the interest of participants, we have a series of questions. Maybe we can, address in subsequent webinars also. But, a lot of overlap already is visible with Wendy's explanation how to link a death with quality improvement system actually is reflected in a couple of questions which, for example, Shalu Gupta has presented to us. That if there is a pediatric early warning system, PUSE is a continuous quality improvement, mechanism also. Now, triage is a well-known standard of care that in emergency room, pediatric triage must happen. And if the audit revealed that that function is not working well in couple of deaths of this kind, then obviously health system in the hospital itself would arrange a triage nurse or a triage training so that the practice improves and the similar death next time can be prevented. So already, there is a link which has been established between the death review systems and quality improvement. It is an ongoing continuous process. So thank you both the speakers of highlighting this, that it's not just a review of a death, an unfortunate death. And, Nuvu reminded us 4.8 million deaths which happened in 2023 across the world. And we believe majority of them are preventable deaths. They happened because of some delays. You remember 3 delay model from MDSR, that delays can happen in treatment from the primary care level, from the home to the primary care to the referral level. And Wendy described a situation where at primary level ORS was not given, so required treatment was not available. And therefore the delay happened, and then case progressed to hypovolemic shock, and then unfortunate death. So not just clinical or medical audit, but a social audit, that what are the modifiable factors, right from the home to the primary level to the referral level, where the finally death happened. So that's typically analyzed, and therefore the solutions are many times within the hospital, but there are solutions, as Wendy and Nuvo were describing, which are across the health system, even outside the hospital and into the community, where we have to explain to them to seek timely help if that is found in a region. So thank you so much for both these speakers for illustrating, especially Wendy, as Nuhu was saying, that please wait for Wendy. She will explain how to actually apply in a low resource setting. And she actually gave us a story from Papua, which is a low performing area in Indonesia, red flag area, she was saying, affected with humanitarian, emergency. So therefore, the gaps which the team would identify without adopting any blaming or naming or shaming, mechanism. It's a blameless learning exercise. Thank you for that reminder again and again, that we have to learn and then improve together. So teamwork actually is a good leveler of hierarchy. So clinicians' ego, if you all, Felix, whoever asked this question, if you practice addressing each other with first name, that also immediately, flattens the hierarchy. And the egos are, gradually diluted, that you are a team. And sometimes the ward nurse is the leader, because she can manage much more variety of things than a doctor. So a lot of stuff, interest has been generated, and we will try to cover some of these in the next few webinars also. And thank you for reminding again and again that point of care quality improvement is a good method of quality improvement. And that is widely available on WHO website of WHO CERO. So not a problem, people can access there. With that, my final request is, after thanking Poonam and Nuhu and Vindi for this beautiful session, that people can, do the feedback form completion so that they can get the participation certificate. So thank you so much, everyone, for joining us. The webinar would also be available as a recording on IPA web platform subsequently. So those colleagues who have registered and may not have been able to join now, and their own networks can be referred to IPA platform for this recording available on the IPA platform. So feedback form you can download with this QR code, fill that up and immediately submit so that we can send you the participation certificate. With that, I would like to end this webinar. Thank you so much once again, Dr. Poonam, Dr. Nuhu, Dr. Vindi, and our President-elect, Dr. Carlos, who presented the opening remarks. And thanks to the IPA office for supporting this platform. Thank you, everyone. Bye-bye.
Thank you, everyone. Yeah, have a good day.
And one more announcement. Sorry. Subsequently, we are doing 5 webinars with WHO on the 5 global patient safety goals, which were announced last year in September. There are 5 global safety goals related to pediatric and newborn care. The first in series, it will be a monthly webinar. The first in series would be on 6th February. So please stand by for the announcement details. We will have series of webinars on global patient safety goals related to pediatric and neonatal care. So thank you so much for your interest. Bye.
Thank you so much, Dr. Rajesh Mehta. And all the participants and esteemed speaker and moderators. While you can also access the feedback form while closing the webinar, you will get an option give feedback. Please click on the link and you can fill the feedback form so we can send the participation certificate. And thank you all the participants and panelists. Thank you so much.
Thank you.